When they walk in to see you, what's usually their main complaint? I don't feel good.
I hurt from head to toe.
I hurt from head to toe. Is that a pretty classic way of saying, uh-oh, I wonder if they've got this, this, or this? What's your differential diagnosis?
Well, that's very patient specific. If you're looking at older patients, you look at things like polymyalgia. If you have patients...
So polymyalgia, what's that?
Polymyalgia is achiness and stiffness in your proximal muscle groups, upper arms, upper legs, difficulty getting up and down, raising your arms overhead, typically in people over 50, and specifically more so even people over 60. And that responds very well to a low dose of steroids for generally a fairly short period of time. So those patients need to be distinguished from the fibromyalgia patients.
So you rule them out, and there are blood tests for muscle breakdown, SED rate, that's what I remember from medical school.
SED rates and PMR, but 25% of the patients have a normal SED rate, so that's not a given, but it helps.
So you rule out polymyalgia. What else do you rule out?
You look for any underlying positive autoimmune tests. A certain percentage of patients who are diagnosed with fibromyalgia will eventually evolve into an autoimmune process.
Now, autoimmune, that would be,
As
I think
in
of
lupus or rheumatoid, something like that. So if they have a high titer ANA or they have a very high titer rheumatoid factor, even though they may not have active inflammation when I initially see them, sometimes the achiness and fatigue is the prodrome to those illnesses.
Must be very difficult on the patient, Kim.
Well, it is.
You know, because they ache all over, they don't feel good, and everybody else says, I can't find it on laboratory work.